Is my screen visible?
Yeah, it is.
Yes. So thank you, sir. So I begin with the case opportunity in an opportunistic infection. So this was a case of a 47-year gentleman who had presented to us with complaints of difficulty in walking and easy fatigability for the past 5 months and weight loss for the past 5 months. So this gentleman had difficulty in getting up from the squatting position and in climbing stairs. It was associated with thinning of legs, but there weren't any sensory disturbances. Also, there were no history of difficulty in the upper limbs. He had marked fatigability. Along with this, he noticed that he had gradually lost around 12 kg weight over this 5 months period. There was not any loss of appetite, any altered bowel habits, or fever. Gradually, he became moribund and subsequently bedbound after an episode of diarrhea, which was managed conservatively at a local hospital. On asking leadingly, the gentleman complained that he had easy bruisability for the past 2 years. He had hypopigmented pruritic lesions on his trunk and limbs for the past 1 year. There was ruddy complexion of the face for the past 1 year. He had low mood and irritability for the past few months. Also, there was history of erectile dysfunction and excessive sleepiness during the daytime. However, there were no history of hyperpigmentation, visual disturbances, polyuria, or polydipsia, no history of loss of libido or decreased shaving frequency, no fractures, stone disease, pain abdomen, dyspnea on exertion, or fever. So he was diagnosed with diabetes 3-4 years back in view of oral candidiasis and polyuria, and hence he was initiated on oral hypoglycemic agents. However, due to poor glycemic control, he had to be initiated on insulin, and his glycemic control had always been poor. He was a hypertensive and he was non compliant on treatment. There was no history of any intake of exogenous steroids or any complementary and Ayurvedic medicines. He was a reformed smoker, and amongst family history, his mother had died at 5 years of age due to some unknown abdominal malignancy. On examination, he had a BP of 140 by 90 mm. He had tachycardia. He had a plethoric round face. He had cuticular atrophy, hypopigmented annular lesions over his lower limb and trunk. There were bruises over his anterior abdominal wall. There were hyperpigmented nails. There was grade 1 acanthosis. However, there were no stria. Also, there was no dorsocervical fat pad or supraclavicular fullness. He had decreased tone and bulk of the muscles. They were flabby, and there was decreased power in both upper limbs and lower limbs. The ankle jerk was absent bilaterally, and there were decreased breath sounds in bilateral infraaxillary areas. Coming to the baseline investigations, he had hypokalemia and an elevated alkaline phosphatase levels. He had respiratory alkalosis and an elevated levels of beta D glucan. Coming to the hormonal profile of this gentleman, he had elevated ATM cortisol, which was 3,400 nanomoles per liter, and an ACTH of 178 picogram per ml. He had borderline elevated DHEAS levels, which was 509 microgram per deciliter. He had low testosterone, which was 6.25 nanomoles per liter, and also low T4, which was 4.2 microgram per deciliter. And his HbA1c was 10.6%, reflecting poor glycemic control. Coming to the HP axis dynamics, yes, he had an elevated 8 am and 11 p.m. ACTH in cortisol with a non-suppressible LDDST of 730 nanomoles. However, his HDDST was suppressible. Short of IPSS, we went ahead with IV ADH stimulation in this gentleman, and it was non-conclusive. The ACTH rose by only 8% and cortisol by 22% at the end of the procedure. So we went ahead and did an MRI SELA for him, and it showed a relatively well-defined differentially enhancing lesion 12 into 8 mm involving the posterior half of the pituitary and the stalk. And the impression given was query exophytic adenoma extending along the stalk, query lymphocytic hypophysitis. Subsequently, a CECT abdomen was done, which was suggestive of bilateral enlarged adrenals with heterogeneous enhancement and hypodense areas within. Query adrenalitis, query bilateral adrenal tumors. In view of this homogeneous opacity in the left parahilar region, we went ahead with a CT chest, which was suggestive of fibrobronchiectatic changes in cavitary lesions with areas of breakdown, suggestive of infective etiology, query tuberculosis. So it was very clear from his history and examination and evaluation that this gentleman was suffering from Cushing syndrome. But what was the etiology? So points to favor ectopic Cushing's were that he was a 40-year gentleman. He had a short duration of symptoms. He presented basically with weight loss. There were no striae or hyperpigmentation, gross hyperpigmentation. The cortisol burden was very high. The IV-ADH test being non-conclusive, and the radiology confused us more. However, we are considering Cushing's disease as a more common cause of Cushing syndrome and attributing his weight loss to uncontrolled diabetes and the fact that he had a suppressible HDD-ST and a stalk adenoma. We put our money on Cushing's disease, and our differentials were Cushing's disease with adrenal hyperplasia with query pulmonary tuberculosis, Cushing's disease with disseminated infection involving both the adrenals and the lungs, and low down was a possibility of ectopic Cushing's lying somewhere with disseminated infection involving pituitary, adrenals, and the lungs. So this gentleman also had an atypical radiology, that was the stalk adenoma. If we consider the normal development of pituitary, we know that it has two parts, adenohypophysis and neurohypophysis. And we know that this adenohypophysis develops from the dorsal invagination of the oropharyngeal epithelium on being stimulated by the neuroepithelium from the diencephalon. And there are normally few cells of adenohypophysis which are lying in the pituitary stalk. So these stalk adenomas, they are not ectopic, but they are derived from neoplastic evolution of these cells normally being found in this stalk. And they can be of two types. One type is the adenoma with extraaxial development, wherein the adenoma arises from the stalk and then grows away from the anterior pituitary. And in this case, the diaphragma sella appears intact. The other scenario is the one where adenoma arises from the stalk and then extends towards the pituitary, and hence it is difficult to make out whether the adenoma arose from the stalk and grew towards the pituitary or it was vice versa. Such adenomas are called as adenomas with intraaxial development. So these stalk adenomas are challenging to the neurosurgeon. Why? Because as illustrated in this picture, we see that in the transsphenoidal transtuberculum cellae approach, the diaphragma sella has to be pierced and the adenoma has to be reached. Then subsequently, it has to be dissected from the infundibulum and hence resected. So in doing so, the difficulties encountered are that the tumor edge is not as obvious as it is with the tumors which arise within the anterior lobe. Also, the pile layer at the interface of the pseudocapsule of the tumor and the stalk is quite tough, and hence sharp dissection is required to preserve the anatomical integrity of the stalk. And hence, some surgeons prefer the superior approach, that is craniotomy, while others prefer the transsphenoidal transtuberculum cellae approach. So this was a case series of 10 patients, wherein they 4 patients had microadenomas with extraaxial, and other 6 patients had adenomas with intraaxial development. And in this case series, they showed that pre-op MRI was correctly able to visualize the tumor location, and it corroborated with the intra-op findings in 6 out of total 10 patients. And all these patients, pituitary stalk was preserved while doing the surgery, and all had remission post adenomectomy and were rendered hypocortisolic. And only one patient in those who had extraaxial development and one in those who had intraaxial developed panhypopit. And amongst the local complications, only one had bitemporal hemianopia. That too because the location was close to the optic chiasma. So this study suggested that these stalk adenomas overall have a good post-surgical outcome. So this was another case from our institute. This was a gentleman who had presented with pain abdomen and was subsequently found to have suffering from acute pancreatitis. He had on evaluation stigmata of Cushing's and an ACTH dependent Cushing's, biochemistry suggestive of ACTH dependent Cushing syndrome. And on MRI, we were able to localize a stalk adenoma. Subsequently, this gentleman was operated upon, and he went into remission, and he was subsequently put on hormonal supplementation. So after all, seeing all the trend of this cortisol, without the gentleman being on any medical management for the same, his cortisol levels had gone on to decrease. So was he really heading towards auto remission? And if yes, what are the possible mechanisms? So we know apoplexy is common in macroadenomas, and however, it has also been reported in patients with microadenomas, which can undergo autoinfarction, hence causing self-remission of the tumor. Also, there can be involvement of the pituitary gland by the infectious process. Similarly, at the level of adrenal gland, there can be glandular infarction because of a bland microthrombi, because of the prothrombotic state seen in patients with Cushing syndrome. Also, there could be fungal infection of the adrenals, which leads to endovasculitis and subsequently fungal emboli causing caseation necrosis. Also, they can be because of the increased ACTH drive and the hyperplastic glands, and subsequently increased blood flow to the adrenals. There can be congestion of the adrenals, and when subsequently endotoxins um, uh, further they are influenced by the endotoxins, they can be hemorrhage into the gland, which we commonly know as Waterhouse-Friderichsen syndrome. So, microadenoma undergoing self-resolution, that too in a stalk, has also been previously reported. This was a case of a 42-year female who had presented with two microadenomas. So, and due to non-availability of IPSS in the institute, this lady was being managed with ketoconazole. After 1 year of medical management, when she finally the ketoconazole was stopped, she presented with symptoms of hypocortisolism and headache. And when subsequently MRI was done, it was suggestive of a disappearance of this microadenoma. So self-resolution does occur in microadenomas, that too corticotropinomas. Similarly, this was another case report from our institute wherein 18-year-old gentleman who had ACTH dependent Cushing's was awaiting TSS, and during the process, in the meanwhile, he presented with skin lesions and varicella pneumonia, and ultimately he developed shock, and on evaluation he was found to be hypocortisolic. So when MRI was done, it was suggestive of apoplexy of his adenoma, and hence the patient had auto remission. So far we have this gentleman who has been diagnosed with Cushing syndrome, who was initiated on antibiotics, pneumocystis carinii pneumonia prophylaxis, and anticoagulation. However, we did not start any medical management because we were doing the dynamic testing. So somewhere in the investigations and imaging, we had some suspicion of infection of the lungs and the adrenals, which could be fungal due to rising beta-D-glucan levels. So we initiated him on antifungals empirically. Subsequently, this gentleman underwent bilateral adrenalectomy on 23rd of February, so as to debulk the disease and offer him cure. However, post surgery, he had a sudden arrest, but fortunately, he was revived and he was on assisted ventilation for almost 3-4 days, after which he was weaned off. So this was the gross specimen from this gentleman. On to the right is the normal hyperplastic adrenals in a patient who has non-infective adrenal enlargement. And on to the left is the adrenals from this gentleman, which were bulky, weighed around 30 to 40 grams, and showed areas of fat deposition and necrosis. On cut section on histopathology, it showed multiple nodules, both large and small, and these nodules were concentrated more towards the medulla of the adrenal. And this focus section of the one of the nodules showed central necrosis within, with palisading histiocytes onto the periphery. So, subsequently, on H&E stain and per iodic acid shift stain, we delineated this multiple variable size spores which had an eosinophilic cell wall, and the impression given was of adrenal histoplasmosis. So, this diagnosis of histoplasmosis was not that too surprising, because somewhere in the radiology and the microbiology workup, there was some hint towards infection. So why are infections in Cushing so common? We know that infections are the second most cause of mortality in Cushing's, just after cardiovascular causes, and the prevalence of infections is to the tune of 21 to 53%. So what are the reasons? So reasons are multifactorial. Cushing's is a disease characterized by hyperglycemia, which can lead to neutrophil dysfunction, can cause glycation of the complement components, rendering them ineffective. Then there is skin damage and there's impaired wound healing, and we know that skin forms the first line of defense. Then subsequently, steroids have a far reaching effects on our immune system. They paralyze both the cell mediated immunity and the humoral immunity, with the major effect being on the cell mediated immunity. They shift the balance from CD4 cells to the CD8 cells. They decrease the endothelial adherence of the neutrophils, their extravasation, their degranulation. They hamper the activity of NK cells, and subsequently they predispose the individual to multiple infections, especially the fungal and the viral infections. So why are these infections so sinistral in Cushing's? So the patients with Cushing's, they are not able to mount fever, they don't have pain. So there are masking of signs of inflammation by the cortisol excess. Also, these infections tend to be disseminated and invasive. There are infections with opportunistic organisms, and co-infections can occur. Also, control of hypercortisolic state can lead to unmasking of occult infections due to reconstitution of the immune system. And not the least, there can be further flare up of the hypercortisolic state due to stimulation of the CRH-HP axis by the cytokines in the phase of infection. So this is a paper by Graham and Tucker who showed that with the varying levels of cortisolemia, the organism which is causing the infection also varies. So a cryptococcosis is seen at levels less than 70 microgram per deciliter, whereas as levels higher than 121 micrograms, the cutoff which they derive from discriminant analysis, pneumocystis infections are more common. And the patients who have uncontrolled hypercortisolemia ultimately succumb to their infections. Subsequently, Sarlis and colleagues showed that with the increasing degree of cortisolemia, the severity and the fulminance of the infections increases. And amongst cortisol, urinary free cortisol, and 17 hydroxysteroids, the maximum predictive value was for 17 hydroxysteroids in predicting the severity of the infections. So coming to the fungal infections in Cushing's. So we know that invasive fungal infections are common. However, the more common organisms are cryptococcosis, Pneumocystis carinii, aspergillosis, and candidemia. Histoplasmosis is also reported, but it is less common. And peculiarity about adrenal histoplasmosis is that it is the local concentration of corticosteroids which is more important rather than the systemic one. And hence, the site of lesion is zona reticularis, wherein there is the maximum gradient of cortisol excess. The patients can present as acute infection or they can be reactivation of chronic infection in areas where the histoplasmosis is endemic. So on searching literature, we could come across only one case of adrenal histoplasmosis reported so far. This gentleman was from Malaysia. He was 45 years who had ACTH independent Cushing's, and he had a Cushingoid habitus with secondary diabetes, hypertension, and osteoporosis. At that time, maybe MRI was not available, so CT was done, which was normal. And he had a left adrenal nodule and subsequently underwent TBA and was offered cure. So, in a patient with Cushing's, we should always look for signs and symptoms of infection. We should consider opportunistic pathogens in our diagnostic workup. If we have doubt of any respiratory infections, we should get a CT scan done and then treat accordingly. Even when the patient does not have any symptoms of infection, we should do the routine screening test for asymptomatic UTI or bacteriuria, and we should consider adding prophylaxis for pneumocystis if the cortisol levels are high. So final diagnosis in a gentleman we made was Cushing's disease with disseminated histoplasmosis, adrenal plus pulmonary, and we initiated him on oral hydrocortisone, fludrocortisone, thyroxine, and itraconazole. However, post addition of itraconazole, his alkaline phosphatase levels began to rise, and they reached as high as 2000. So our possibilities were maybe if it was drug induced, or since the gentleman had high ALP to the begin with, it could be some granulomatous hepatitis. Maybe the fungus is infecting the liver as well. Or it since the patient had undergone CPR and there were few rib fractures, it could be bone-derived alkaline phosphatase. So considering that, we changed the antifungal therapy to liposomal amphotericin B. So at follow-up, after having received 20-30 days of amphotericin B, this is how the gentleman looks like. His plethora has disappeared. He has lost weight. He has a tracheostomy which is planned for decannulation soon. He has the homogeneous opacity in the left parahilar area has also disappeared. So our plan is to continue antifungals and decide on the long-term therapy for disseminated infection in this gentleman. He is on hormonal supplement replacement, anticoagulation, and our plan is to rehabilitate him in terms of muscle strength, bone health, and glycemia, which has improved significantly post surgery, and to monitor ACTH levels and interval change in the size of the adenoma for Nelson's. So the learning points in this case were that we should always have a high index of suspicion for occult infections in patients with Cushing syndrome. Stalk adenomas, though rare, do occur in clinical practice and they have good post-op outcomes. Bilateral adrenalectomy may be life-saving in certain situations. With this, I thank you all for your patient listening and my department, especially Professor Pinaki sir, for giving me a chance to present here.